Transfusion therapy in selected patient populations, finding the right component for the right situation. So we've gotten the samples, everything's good to go. We've cross-matched if we've needed to. We've done all the testing. So we're finding out, who needs what blood on what situation. Acute blood loss. This is rapid blood loss from a hemorrhage, for example. It affects an electrolyte balance, it affects oxygen transport, it increases the heart rate, stresses your internal organs, and can result in cardiac or renal failure. Treatment for acute blood loss, we want to maintain the fluid volume to keep blood vessels from collapsing. We're going to do this through IV fluids or crystalloids, which are volume expanders. This is going to be based on the patient's vital signs and clinical situations. Do they need RBCs, plasma, platelets, or cryo? A massive transfusion, as we know, is a replacement of a patient's entire blood volume in 24 hours. This often requires the use of uncross-matched blood or emergency release blood. Can cause adverse metabolic effects such as citrate toxicity, hypothermia, and coagulation abnormalities. So why are we thinking hypothermia? Well, if we're pushing blood into a person in emergency situations with that massive amount, blood is kept, we know, refrigerated, so we have that issue of dropping our body temperature to unsafe levels. For cardiac surgery, there's a procedure called a coronary artery bypass graft. They also call that a cabbage, which the blood circulates on a pump outside of the patient's body. Very interesting if you want to Google that. It's not for the faint of heart to see how that's worked. It's crazy. Heparin causes an APTT increase, which you may need fresh frozen plasma. Impair platelet function, so you may need plateletpheresis unit. Preoperative aspirin warfarin can contribute to uncontrolled bleeding, so you may need vitamin K, fresh frozen plasma, and platelets. Neonatal and pediatric transfusions, sick neonates are very likely to need transfusion support. We have higher levels of hemoglobin F, which have a higher O2 affinity, and erythropoietin levels are not as responsive to low levels of oxygen. You may also have atrogenic blood loss, and atrogenic is basically says from a treatment or sample collection. When my baby was super young in the NICU, he needed a transfusion because he was getting hill sticks for having blood gas taken so often that he had an atrogenic blood loss at a level they didn't like. So gave me a unit, he was good to go. Again, we've taught this before, the little bit of review. Selection of blood for neonates. The mother's sample is used for an antibody screen and cross-match. Products are given in small volume aliquots. Fresh cpDA blood is most often given to maximize the 2,3 DPG levels. You can give them other types, but sometimes that is the preferred additive for the blood to give them. They're going to select glucoreduce, irradiated, CMV negative, and most often going to give them O negative RBCs. For organ transplant patients, the transfusion support is going to differ according to which organ is being transplanted. We're going to give them HLA matched, so we're trying to prevent transplant rejection, and ABO compatible. Non-ABO compatible may be done with therapeutic plasma exchange and anti-rejection drugs. It happens sometimes, especially if they have a better HLA match. For hematopoietic progenitor cell transplants or stem cell transplants, these cells can be obtained from bone marrow, peripheral blood following colony stimulating factors, or umbilical cord blood. Again, these transplants can be autologous or allogeneic. For HPC transplant blood product support, we're going to give leukocyte-reduced RBCs and platelets, irradiated blood to prevent graft versus host disease, and the ABO must be compatible with both the recipient and the donor. If we look at table 16.6 on page 375, we're going to have some therapeutic uses for hematopoietic progenitor cell transplantation, such as to treat congenital immune deficiencies, malignancies and cancers, and other things such as multiple sclerosis or paroxysmal nocturnal hemoglobinuria, which is PCH. So some transplant terminology, we've used a couple of these before. Allogeneic is going to be from an individual of the same species. Syngeneic is from an identical twin. Autologous is from self. And xenogeneic is from another species, such as getting a cow heart, for instance. For therapeutic apheresis, we've talked about therapeutic phlebotomy before, but for the apheresis part, remember, we're taking certain parts out and we're going to be putting other things back in. So what we're going to do here is try to remove abnormal cells, plasma, or plasma constituents from a patient's blood to achieve a clinical benefit. We're trying to limit inflammation, reduce the amount of autoantibody or alloantibodies, and also to clear antigen-antibody complexes. the replacement fluids for therapeutic apheresis, or what we are replacing after we have taken out what we don't want, is going to differ according to what conditions we're talking about. This could be albumin, this could be crystalloids, or it could be plasma. If it is plasma, it's going to require some involvement with a blood bank or transfusion service to acquire the plasma. If we look at table 16.8 on page 378, we're going to see some indications for therapeutic phlebotomies and what their purpose is, such as plasmapheresis with Guillain-Barré syndrome to remove pathogenic autoantibodies, cytopheresis with sickle cell disease, which reduces hemoglobin S, replacing it with the adult hemoglobin. And we could also have photopheresis. If we have allograft rejections, this is going to inhibit lymphocyte proliferation and cause induction of apoptosis. With oncology patients, chemotherapy and/or radiation therapy often causes the patient's need for transfusion support. A lot of times we're talking about platelets and RBCs. These may need to be irradiated, CMV negative, and potentially HLA matched, really with platelets only. With chronic renal disease, dialysis patients may often experience hematologic complications. You may have splenic sequestration of RBCs and/or platelets. That's a mouthful. Dialysis may cause RBC hemolysis, and inactive kidneys do not produce what important hormone? We need it for RBC production, erythropoietin, HUS, and TTP. So we have hemolytic uremic syndrome and thrombocytopenic purpura, TTP. With these, we have symptoms of thrombocytopenia, microangiopathic hemolytic anemia, renal dysfunction, and CNS involvement. For some anemias requiring transfusion support, probably one of the biggest ones is sickle cell anemia. And with these patients, we need to give them hemoglobin S negative units. We want to phenotype the patient before transfusing, giving antigen negative blood when feasible. These people normally require a good bit of therapy, going from simple transfusions into exchange transfusions, sometimes on a monthly basis, which has them often requiring chelation therapy. And chelation therapy is removing excess iron, and simply because they've received a whole bunch of RBCs. We phenotype the patient before transfusing because a lot of times sickle cell patients are what are called high responders. They think that these people more likely to form antibodies, but it's one of those things that if you're getting more blood that is not your own, you will have a higher propensity to form antibodies. So it kind of goes hand in hand. With thalassemia, we're going to have RBC and chelation therapy. With aplastic anemia, we have hypocellular bone marrow. They need all types of products here, especially RBCs and platelets, based on their functionality. With immune hemolytic anemias, we have autoimmune, drug-induced, and alloimmune anemias. For those with hemostatic disorders, we're going to need fresh frozen plasma or cryoprecipitate. If this comes from a decrease or lack of production of one or more of the coagulation proteins, we're talking about hemophilia A or B or von Willebrand's disease. These could have normal production but abnormal structure of proteins, rendering it non-functional. Some acquired hemostatic disorders are DIC, which is disseminated intravascular coagulation, which you can be bleeding and clotting internally at the same time, not fun to have, and liver disease or damage. You also have alternatives to transfusion. We know that blood supply is limited amount, it's dependent upon the donors. And some places like to do anything they can before the person becomes transfusion dependent, because a lot of times it may be the last line of defense, what's keeping them alive. So we can do lyophilized coagulation factors, which are usually kept in the pharmacy. We can use volume expanders such as crystalloids, colloids, albumin, or plasma protein fractions. You can also give hematopoietic growth factors to stimulate bone marrow production of RBCs, platelets, and leukocytes. We sometimes will say, especially if a person has a very hard to match blood, or blood that we know based on their autoantibody we're not going to get compatible blood, we can say, is this person a candidate to get erythropoietin so they can start spitting out their own RBCs, so we don't have that additional issue. Now sometimes it's not always bad to give transfusion because that's the best choice. Someone has low hemoglobin, if they're not a candidate to get these hematopoietic growth factors, we know that a unit is going to be a quick fix sometimes, while doctors and providers try to figure out what the underlying issue is. And finally, for this one, a transfusion committee. Its function is to review blood usage and set or change hospital criteria for blood product administration. We're looking here and they're looking to see what type of blood has been ordered, um, including blood type and blood product type, to determine what their needs are met or if they need to make some changes. So if they see that, they've had 80% order of O negative blood and they have not had 80% of their patients be O negative, to see where that disconnect is and how to change that. This is usually going to include transfusion service directors, surgeon, anesthesiologist, and oncologist. It's going to ensure appropriate procedures are followed and you're not ordering too much or too little blood or the right type of product and kind of all that, which brings this one to a close. See you next time.